We are really grateful to have you all here as we dive into the important topic of chronic liver disease, and where we'll be discussing stages of liver failure and all that pertains to liver pathology and management. But before we get started, inshallah, we would like to open with a word of prayer. And from our brother Said, please go ahead.
بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
And Sadaqallah al-Azim, thank you for the wonderful recitation. And let's start. And first of all, we are really honored to be joined by two of our esteemed facilitators, and Dr. Hadi, who is a consultant physician and a gastroenterologist at the Dr.Hadi Gastro Center. He holds a medical degree from China, a Master's of Medicine in Internal Medicine from the University of Nairobi, and did his fellowship in gastroenterology at the University of Pretoria. He is a fellow of the College of Physicians and also the College of Medicine of South Africa. Dr. Hadi is an active member of the Kenya Association of Physicians and the Gastroenterology Society of Kenya and the South African Gastroenterology Society. His professional interests include gastroenterology, oncology. And the second facilitator is well known to most of us and none other than Dr. Dekkow, who is a senior registrar at the University of Nairobi. And we are also honored to be joined by two of our presenters, both level 6 MBChB, Ayaan and Ruqiya. And Ruqiya, you can go ahead with your presentation, inshallah.
Okay, thank you, Mustafa. Please confirm that you can hear me.
Yes, we can hear you.
Okay, so my name is Ruqiya Mahat, a final year medical student, and I will be taking you through the history, and Ayaan Hassan, a fellow final year medical student, will be taking you through the discussion, inshallah. Okay, so let's start. So biodata, I'm presenting Hassan, a 48-year-old male who resides in Dandora and is a construction worker. He was admitted on the 12th of April, 2025, that was 10 days ago, and was discharged on the 18th of April, 2025. Presenting complaints were abdominal swelling for 1 month and lower limb swelling for 1 month. Onto his history of presenting illness, he was relatively well up until 1 month prior to his admission when he started experiencing abdominal swelling. That was global, gradual in onset, and progressively worsened. It was not painful, and there were no exacerbating or relieving factors. It affected his activities of daily living in that he could no longer go to work. It was associated with difficulty in breathing that was gradual in onset and progressively worsened to NYHA class 3. However, there was no cough, no chest pain, no orthopnea, no paroxysmal nocturnal dyspnea, and no platypnea. It was associated with decreased appetite. However, there was no vomiting, no yellowness of the eyes, no itching, no bleeding while brushing his teeth, and no easy bruising. Around the same time, he started experiencing multiple episodes of watery, non-bloody, yellowish mucoid stool about 6 to 8 times in a day. That was associated with mild hotness of the body that resolved after 2 days. However, there was no weight loss, no night sweats, and he's not been in contact with anyone who's had similar symptoms. His lower limb swelling started gradually on both legs at the same time, from the toes up to the level of the ankle. It would leave an imprint when he would wear his shoes. It was worse during the day when he would sit for long periods. However, it wasn't painful, no associated color changes, no altered sensation at any point, no associated urinary changes, both color and amount, no frequency, no urgency, no dysuria, no hematuria, no periorbital edema at any point. He also complains of excessive fatigue that progressively worsened for the past 6 months prior to his admission, that was associated with awareness of heartbeat, dizziness, one episode of loss of consciousness for about 5 minutes while working, on and off headaches, however, no convulsions or any focal neurological deficits, and no confusion or any changes in behavior at any point. He didn't seek medical attention as he attributed his symptoms to working, so he didn't seek any medical attention. Onto his risk factors. He's a chronic alcohol user for the past 33 years, has been drinking 1.5 liters per day of different liquors, ranging from spirits, beer, illicit brew, and the last time he drank was 2 weeks prior to his admission. He's an occasional cat chewer 3 to 4 times a week, never smoked or used tobacco, no IV drug use, never been treated for hepatitis. He claims to have had 1 sexual partner. He denies the use of both over-the-counter and herbal medications. He uses store-bought flour. He has no chronic illnesses like DM or hypertension, no family history of liver disease. He drinks untreated tap water. Mostly it's at hotels when in Nairobi, and when he visits his family, the wife cooks for him. Onto his past medical history. This is his 2nd admission. He underwent a hernia repair surgery last year in March at KNH, has had no previous blood transfusions, no non-food or drug allergies. Onto his family social history. He's a 7th born in a family of 11. He has 7 sisters and 3 brothers that are all alive and well. He's married with 4 children, 2 boys and 2 girls that are all alive and well. His family stays in Marsabit while he works here. His mom is hypertensive. Dad died when he was 9 years old. He does not know what the problem was. He's a high school graduate, had to drop out to help his mother, has SHA and is active. Onto his review of systems. It was unremarkable, apart from the fact that he complained of having toothache that was causing occasional headaches, and so he's due for a dental appointment. So in summary, I'm presenting SM, a 48-year-old chronic alcohol user for the past 33 years, presenting with a 1-month history of progressive abdominal and lower limb swelling associated with decreased appetite, mucoid diarrhea, grade 3 dyspnea with no jaundice, no hematemesis, no melena, and no bleeding tendencies. Onto his general examination, I found a middle-aged African man, sick-looking, lying supine, fully alert and oriented in place, person, and time. He had no obvious signs of respiratory distress or wasting. He had a cannula in his right hand. His vitals were, so his blood pressure was 126/84, which was normotensive. Respiratory rate of 17 breaths per minute, which was eupneic, pulse rate of 95 beats per minute, which was normal. He was saturating at 95% on room air. His temperature was normal at 37 degrees. His cup refill was prolonged to 4 seconds. Continuing with his general examination, there was pallor. Pallor was present, mild palmar pallor and conjunctival pallor, as well as bilateral pitting edema up to the level of the knee. However, there was no jaundice, no clubbing, no cyanosis, both peripheral and central, no lymphadenopathy, and no signs of dehydration. He had no peripheral stigmata of chronic liver disease, that is, no palmar erythema, no Dupuytren's contractures. Yes, and he had no leukonychia or koilonychia. Onto his systemic examination, his per abdomen. On inspection, the abdomen moved with respiration. There was flank fullness. Umbilicus was everted. There was stray around the umbilicus that was hypopigmented. He had a scar in his left and the right iliac fossae, secondary to his inguinal hernia surgery. He had no scratch marks, no spider nevi, no distended veins, and no gynecomastia. On superficial palpation, there was no tenderness and no obvious masses. And on deep palpation, the liver edge was not palpable and there was no organomegaly. On percussion, the fluid thrill and shifting dullness were both positive. His liver span was 6 centimeters. On auscultation, his bowel sounds were present, normal pitch, about 7 per minute. No bruits were had. Onto his cardiovascular system. On inspection, there was a normoactive precordium, no chest deformities, no scars, and no distended neck veins. On palpation, the apex bit was palpable in the fifth intercostal space, mid-clavicular line. The trachea was central, no heaves and no thrills. On auscultation, S1 and S2 were heard. There were normal pitch, no added sounds or murmurs. Onto his respiratory system. On inspection, there was symmetric chest movement with respiration, no scars or deformities. And on palpation, there was symmetrical chest expansion, normal tactile parameters. On percussion, it was resonant through all lung fields, and on auscultation, there was equal vesicular breath sounds heard bilaterally. Onto his CNS, his GCS was 15 out of 15. All cranial nerves were intact. He had no motor or sensory deficits. So my impression was this patient had decompensated chronic liver disease with ascites, likely secondary to alcohol-related cirrhosis and portal hypertension. And he could also be having acute gastroenteritis, as is evidenced by several episodes of watery mucoid non-bloody diarrhea. And it could actually be that the gastroenteritis was the triggering factor in this patient that now tipped him over to the decompensation. So on investigation, I'll start with the labs and go to the imaging. So he was admitted on the 12th of April 2025, whereby a full hemogram was done, and it revealed normocytic, normochromic anemia with thrombocytopenia. So he had a HB of 9.5 grams per DL, which was low, an MCV of 87.8, which is normal, a hematocrit of 30.5, which is also low, and a platelet of 81, which was low. His most recent full heme revealed now a pancytopenic picture with WBCs of 2.99, HB of 8.5, and a platelet of 60. And we're going to see why it is that it was pancytopenic. So onto his liver function tests. His total bilirubin was slightly elevated at 30 micromoles per liter. Upper reference limit was 21 micromoles per liter. Both his GGT and his ALP were elevated to 9 and 1.5 times their upper reference limits, respectively. The AST and the ALT were both elevated, and the ratio was 3. Albumin was low at 20 grams per liter. The normal range is 39 to 50. Onto his UECs. So the UECs that were done UECs were done 12th, 13th, and 16th. He came in with elevated urea and creatinine of 17 and 236.8 millimoles, respectively. And as he was admitted to the ward and fluids were administered, the urea and the creatinine came down, but still elevated. So you can see the last urea and the creatinine on the 16th, which is the most recent one, was at 171, still decreased from the 236, but still elevated. And his urea was at 14, decreased from 17, again, still high. So his triple serology was also done. That includes his hepatitis B, hepatitis C, and his HIV. They were all non-reactive. His free T3, TSH, and folate were all within range. His glycated HB was low at 4%. His serum albumin ascites gradient was elevated to 1.5 grams per DL. However, a protein analysis was not done in this patient. Several tumor markers were also done, including carcinoembryonic antigen, alpha-fetoprotein, CA19-9, CA15-3, and they were all within range except the CA125-2, which was significantly elevated at 609.9, and the normal range is 0 to 35, and that could be attributed to his ascites. Stool microscopy was also done on the 12th of April, which revealed cysts of blastocystis hominis, and a repeat that was done on the 16th revealed no cysts. Ascitic fluid microscopy was also done on the 15th, and there was no growth of organisms So that's it for his labs. His imaging, an ultrasound that was done when he was admitted revealed a markedly reduced liver size with irregular surface contours, an enlarged spleen measuring 17 centimeters, and that could be explaining the pancytopenic picture that we're seeing on full hemogram. There was free peritoneal fluid in the potential species. A CT has been recommended for further evaluation, and he's currently awaiting the same. His chest X-ray was also done that same day. Both lungs were well aerated with normal vascular markings. There was no evidence of pleural effusion. The cardiophrenic and the costophrenic angles could be appreciated. There was no evidence of consolidation. His management at KMH, he was received at casualty and admitted to the ward where an ascitic paracentesis was done twice, with no albumin administration due to the fact that the hospital did not have albumin, unfortunately. He was initiated on Lasix 40 milligrams IV 3 times a day and aldactone 100 milligrams once a day, as well as metronidazole 400 milligrams 3 times a day, zinc sulfate 20 milligrams once a day. He received paracetamol 1 gram intravenously, but was discontinued after 1 day, as well as esomeprazole 40 milligrams intravenous once a day, fluranone 3 times a day. So the plan for his discharge is that a CT abdomen is to be done as outpatient. And in the meantime, he's on Lasix 40 mg BD for 1 month, aldactone 100 mg OD for 1 month, and esomeprazole 40 mg OD for 1 month. Thank you. If there's no questions or clarifications, I'll invite Ayaan to take us through the discussion.
Dr. Hadi, anything before the next presenter? I think in the interest of time, maybe we should continue and then make the remarks at the end. Tari, can you hear me?
Yes, I can hear you. I can go ahead. Go ahead.
All right, thank you.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Ruqiya, for your presentation, and Dr. Dekkow and Dr. Hadi for joining us today. My name is Ayaan Hassan, level 6 medical student, and I will be taking us through our chronic liver disease discussion. Ruqiya, if I might ask you to present for us, kindly.
Can you see my screen? Yeah.
Yes, I can see your screen. It's still on your presentation.
Oh, okay. It's still on my presentation?
Yes, on the last slide.
Okay.
Okay, yes. Now we can. Perfect. Yes, now we can see. Thank you so much. So as I said, I'll take us chronic liver disease, the discussion bit. My name is Ayaan Hassan, and I'm doing this together with Ruqiya Mahat. Next slide. So by definition, chronic liver disease is now it's a histological diagnosis which indicates progressive destruction and regeneration of liver parenchyma, which would eventually lead to fibrosis and cirrhosis. So there would be extensive fibrosis and formation of regenerative nodules on the liver. So the timeline for it to be called chronic liver disease is 6 months and above, and it ranges from asymptomatic fibrosis, and I put quote unquote there, we would see why, because it's not really asymptomatic, to decompensated cirrhosis. Put a little picture there, which shows us the phases of liver injury. As we know, the liver is regenerative. So we have a bit of liver injury, part of the phases of liver injury that is reversible, and it reaches a point where it's irreversible. So from normal liver to fatty liver, or I want to say literal injury, to up until the point of fibrosis, the injury to the liver is reversible. And once it now progresses to cirrhosis, it now changes to irreversible injury to the liver. Next slide. Okay, so we'll go through the etiological causes of chronic liver disease, and I've tried to group them under different sections, but I've put alcoholic liver disease as the main cause in our setting because of the drinking culture that we have. So I've put alcoholic liver disease, and then the rest of them are grouped into different causes. So for infectious causes, we have hepatitis B, hepatitis C, and hepatitis D. Viral infection, obviously you would expect we need to have a co-infection with hepatitis B, schistosomiasis, leishmaniasis, and malaria. For autoimmune, you can have autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. For drug-induced liver injury, you can have acetaminophen, you can have opiates, benzodiazepines, and then there is chronic ingestion of aflatoxins, where, as Ruqiya talked about, we need to ask the patient about how do they grow their own grains, how do they store their grains, or is it store-bought? For metabolic or genetic causes of chronic liver disease, we have something called metabolic dysfunction associated steatotic liver disease. That's a mouthful, but it was previously called non-alcoholic fatty liver disease. We have hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency. All of those now come under metabolic or genetic causes of chronic liver disease. For congestion or vascular anomalies, we would have Budd-Chiari syndrome, which is genetic, or cardiac cirrhosis, or in simpler terms, right-sided heart failure. Next slide. So for the clinical features, I've grouped them into early stage. Yes, thank you. For the clinical features, I've grouped them into early stage and progressive. So for the early stage is where now I was calling them asymptomatic, because it's non-specific features that the patient would present with, and in some texts it's called compensated chronic liver disease, and the patient would now present with fatigue, malaise, right upper quadrant discomfort, anorexia, and weight loss. In progressive chronic liver disease, patient would present with jaundice, pruritus, ascites, spontaneous bacterial peritonitis. I think some of it is not being seen, but there's hepatorenal syndrome, which we will all talk about. I don't know, there should be more to that slide. Let me just try to access it from my phone. Hepatorenal syndrome, hepatic encephalopathy, which we will all look at. Maybe it will be visible once we share the slides. But those are some of the symptoms of progressive chronic liver disease. Next slide. Okay. I've tried to put a number of pictures that would show a stigmata of chronic liver disease. So starting from the top left is ascites, and ascites on inspection, hepatomegaly on palpation. You'd have cirrhosis on imaging and biopsy, caput medusa, which is usually paraumbilical dilation of veins, gynecomastia due to hyperestrogenism, that is part of the sequelae of chronic liver disease, jaundice and icterus, palmar erythema, and here you would want to appreciate the fact that the center of the palm is not erythematous, which is a bit paradoxical, and you would look at the thenar, hypothenar, and essentially the center of the palm is not erythematous. When we talk about palmar erythema, you have spider nevi, ecchymosis, leukonychia, finger clubbing, asterexis, and factor hepaticus, which is now that the scent characteristic order due to aromatic compounds. Something that might not be included now in this slide, which would be part of stigmata of chronic liver disease, would be again, due to the hyperestrogenism that's seen in chronic liver disease, other than the gynecomastia, you would have hypogonadism or testicular atrophy, decreased body hair in men, and amenorrhea in women. I think for the most part now, the rest of it is mentioned in this picture. Next slide. Thank you. So there are features that are specific to underlying cause or might guide you to underlying cause, especially for the genetic causes of chronic liver disease. I've just picked that one because they're not so common in our setting. For hemochromatosis, patient would present with, dark bronze skin or signs and symptoms of diabetes, which is also called bronze diabetes because of dysfunction or disease associated to the pancreas. Wilson's disease, patient now, other than now features of chronic liver disease, they would also present with psychiatric symptoms and symptoms of Parkinsonism. For alpha-1 antitrypsin deficiency, they would present with signs and symptoms of COPD, particularly emphysema. All of this now together with the chronic liver disease. Try to single that out because they're not so common, but we also have these different symptoms that might lead you to a specific diagnosis. Next. Okay. Something is going on there, but we'll try to fix it. So diagnostics, going on to the diagnostics, we will start with the routine lab studies. So you would want to look at your liver chemistries. For transaminases, you would have obviously high ALT and AST. And if the limit is more than 15 times above the upper normal limits, it would direct you to causes such as acetaminophen ingestion, acute viral hepatitis, or autoimmune hepatitis. ALT ratio more than ALT higher than AST would be indicative of like just general. It wouldn't really direct you to any specific cause. AST higher than ALT would indicate alcoholic liver disease. You would also have high GGT, high ALP. For bilirubin, may be normal initially at the beginning of the disease, but becomes raised in advanced disease. Inversely, you'd have transaminases, which would be raised in initially at the beginning of the disease, but towards advanced disease, due to loss of hepatocyte function, transaminases may be normal or slightly raised. Coagulation profile, you would have high PT and INR due to the synthetic liver function of coagulation profiles. For CBC, you would have thrombocytopenia, anemia, and leukopenia. For the anemia, usually it's due to B12 deficiency or splenic sequestration. Leukopenia, neutropenia due to hypersplenism. For the thrombocytopenia, it is usually due to thrombopoietin, lack of thrombopoietin production by the liver. For the basic metabolic panel, you would have low albumin, low total protein, and hyponatremia. So low albumin, low total protein is because of now, again, the synthetic function of the liver. For hyponatremia, you would have, it would come about in the setting of ascites, where you have fluid retention. Next. Okay, so other lab tests that you can do, maybe that would lead you to a specific diagnosis. For hepatitis, you can do your hepatitis serology. For hemochromatosis, you can do your serum iron, ferritin, and transferrin saturation levels. Autoimmune hepatitis, you would look for your total IgG or serum electrophoresis, your ANA antibodies, asthma anti-LKM1 antibodies. For alpha-1 antitrypsin deficiency, you would look for alpha-1 antitrypsin level and the phenotype of alpha-1 antitrypsin. Wilson disease, you would check the levels of serum ceruloplasmin, serum total and free copper, and urinary copper. For primary biliary cholangitis, you would look for your anti-mitochondrial antibodies. So that is AMA or AMA M2, your ALP, and your bilirubin. primary sclerosing cholangitis, you can look at your cholestasis parameters, and you can do your other tests, ammonia, which now when you're looking for your hepatic encephalopathy, and your plasma cholinesterase. Next. Okay, so I've tried to include your Child-Pugh score. So essentially what the Child-Pugh score is, it tries to use these tests to try and find what is the prognosis of disease in a patient. Okay. So you have these different, maybe we'll share the slides and you can go through it at your own time, but you add points and you look at the cumulative points that would give you either class A, class B, or class C, and the prognosis is the survival rate for that patient in 1 year. Sorry, 1 year survival for that patient. So class A, which is 5 to 6 points, is 100%. Class B, which is 7 to 9 points, is 80% of 1 year survival, and class C is 10 to 15 points, which has 45% survival in the next 1 year. Next. Thank you. Okay, something is happening here again. Imaging. So what would you want to do for imaging? You would want to look at your abdominal ultrasound. You would want to do you want to do a CT, liver biopsy, or an EGD. So what would you see in an abdominal ultrasound? When you look at the structure of the liver, the surface is nodular and the septa is fibrous. I wanted to include a picture. I hope I've included, or maybe not. I'll edit it one last time and send it. Size, for the general size of the liver, initially it's enlarged, and then as disease progresses, the liver becomes atrophied. The abdominal ultrasound can also show you other complications, such as portal hypertension, and it's also used in screening for hepatocellular carcinoma. I think every 6 months, the patient is supposed to do an ultrasound. For your CT abdomen, you'd want to do a triphasic CT abdomen, and the findings are usually similar to ultrasound. Liver biopsy, you would want to do it in case of a diagnostic uncertainty. It's usually the gold standard. So when you would use liver biopsy, it tells you what is the exact cause of that, or the underlying cause of that chronic liver disease. EGD, you do at the time of diagnosis, and then you do it every 1 to 3 years, and this is usually to screen for esophageal varices. Next. Okay, again, the same thing is happening here. For treatment, we will try to tackle it initially for the underlying cause. So alcoholic liver disease, obviously, would be cessation of alcohol. Patient has to stop taking alcohol. Hepatitis B, you can either do tenofovir plus lamivudine or pegylated interferon gamma, such as entecavir. Hepatitis C, there's different regimens, but I've just included one of it here, glecaprevir plus brentasvir. And then, or you would want to give vaccination to a patient. Let's say a patient has chronic liver disease due to a different cause than one of, let's say, if it's not hepatitis, you'd want to give them a vaccine for hepatitis. So hepatitis A/B vaccine. Another vaccine you could give them is pneumococcal, influenza, recombinant zoster vaccine, and COVID-19 vaccine. You would want to avoid hepatotoxins. So what are the hepatotoxins we talked about? These include NSAIDs, opiates, benzodiazepines, and herbal medication. So you'd advise the patient to stay away from these, and medication adjustment. If the patient is on any medication, you would want to adjust them because of the metabolic function of the liver. Next. Okay, complications of chronic liver disease. So once complications set in, now it becomes decompensated chronic liver disease or cirrhosis. And the risk factors for decompensation, the underlying, or maybe not the underlying, but the starting point of these the development of these complications is usually portal hypertension. I hope I'm putting it well. The underlying cause for majority of the complications manifesting is usually portal hypertension. So that's the starting point. But we've said a patient, the timeline for chronic liver disease is usually 6 months. So what would tip over this patient to start presenting with these decompensated chronic liver disease at the hospital? Something has to trigger them to decompensate. Okay, so this would be alcohol use in a known chronic liver disease patient, or a new onset viral hepatitis, or they've taken the medication that we've called hepatotoxins, or they've had a recent infection, surgery, trauma, or obesity. These are trigger factors for decompensation in chronic liver disease. Again, the way we've said, portal hypertension is the starting point for a lot of complications of chronic liver disease. So we'll start to tackle a couple of them, and then I think I've listed the rest. Next. Okay, so we will start with variceal hemorrhage. So a patient will present with upper GI bleed. So you'd have hematemesis and or melena stool. But we've said that the underlying cause is portal hypertension, right? So what would you want to do for this patient? You can either, once they've started, the initial presentation, the first presentation that they present with variceal hemorrhage, you can give them vasopressin, somatostatins, and their analog, so talipressin and octreotide, respectively. A patient has now presented with variceal bleeding for the first time. How do you prevent variceal bleeding afterwards? So you can either do endoscopic variceal ligation plus beta blocker. And the beta blockers that we use is carvedilol, which is usually preferred for small varices. You can do propranolol 20 milligrams twice daily, or you can do nadolol 20 milligrams once daily. Next. Another complication would be ascites, which is accumulation of fluid within the peritoneal cavity, and it's the most common complication of cirrhosis. For management, you would want to do dietary sodium restriction plus diuretics plus fluid restriction. So for the diuretics that you would use, you would do spironolactone 100 milligrams per 24 hours, and the maximum you can go is 400 milligrams. And if the response is poor, you can add furosemide to a maximum of 120 milligrams every 24 hours. Next. Spontaneous bacterial peritonitis. This is usually an infection of pre-existing acidic fluid. And usually there's no evidence for intra-abdominal secondary source, such as perforation of the GI tract. And it cannot happen without ascites. So clinical manifestations now, what the patient present with in spontaneous bacterial peritonitis is fever, abdominal pain and tenderness, altered mental status. Diagnosis, you can do paracentesis, which would show you a WBC count of more than 500 millimeters per cube, or neutrophilia of more than 250. You can also do culture. For treatment, you can do IV ampicillin or plus sulbactam, or a cephalosporin third generation, such as cefotaxime. Next. Another complication of chronic liver disease is hepatic encephalopathy. So hepatic encephalopathy is a spectrum of reversible neuropsychiatric abnormalities seen in patients with liver dysfunction. The disturbance now would be in sleep pattern. There would be loss of balance, overt neurological signs. There would be hyperactive deep tendon reflexes, asterixis, and decerebrate posturing. So opisthotonus would also be present, but it's less common. So how would you want to treat? It includes now synthetic disaccharides, such as lactulose, or you can do rifaximin. So how lactulose works, it causes colonic acidification and now would eliminate nitrogenous waste, or you can use any other cathartics for that matter. Next. So this is the West Haven criteria for grading hepatic encephalopathy, and it usually has 4 grades, from grade 1 to grade 4, ranging from changes in cognitive function up until coma. So grade 1, you would have lack of awareness, euphoria, anxiety. Grade 2, you would have lethargy, subtle personality changes, inappropriate behavior. Grade 3, now they would be semi-stupor, but they would still respond to verbal stimulus. A higher grade of confusion and disorientation in general. And grade 4 would be now coma. So unresponsive to both verbal and nauseous stimuli. So that's the West Haven criteria used to diagnose hepatic encephalopathy, or grade, not diagnose, grade hepatic encephalopathy. Next. Hepatorenal syndrome. So now, what essentially in hepatorenal syndrome, there would be arterial vasodilation in the splanchnic circulation due to portal hypertension, like we've talked about, and this would now cause hemodynamic changes in the body and decline in kidney function, and would lead to hepatorenal syndrome and eventually AKI. And this is usually a diagnosis of exclusion. The mainstay treatment as of before the definitive treatment would be using a vasoconstrictor, e.g. talipressin or norepinephrine, but the definitive treatment for hepatorenal syndrome is liver transplant and adjunctive IV albumin. Next. So the last stage of chronic liver disease would be hepatocellular carcinoma, which is a topic on its own. So they would, patients who have chronic liver disease obviously at an increased risk for developing hepatocellular carcinoma. But different causes of chronic liver disease have a different risk for hepatocellular carcinoma. So patients who have hepatitis B, hepatitis C, hemochromatosis, those are at a higher risk for developing hepatocellular carcinoma. But patients now who present, or the underlying cause of their chronic liver diseases, things like autoimmune hepatitis, Wilson disease, these ones would now have a lower risk of developing hepatocellular carcinoma. Other complications of chronic liver disease would be portal hypertensive gastropathy. Again, all of these tied to the portal hypertension. Portal hypertensive gastropathy, not included in these slides, portopulmonary hypertension, hepatopulmonary syndrome, and hepatic hydrothorax. I think that's the end of my presentation. Yes, thank you so much.
And Dr. Hadi, the floor is yours.
Hello, assalamu alaikum. That's an excellent presentations from Ayaan and Ruqiya. I just wanted to add a few points to clarify and to help to summarize what they have presented. Okay. Let me start. The term decompensation and compensated cirrhosis, this has to come very clearly. You can only call decompensated cirrhosis if they present with only 4 things: variceal bleeding, ascites, spontaneous bacterial peritonitis, and hepatorenal syndrome, and hepatic encephalopathy. Can you hear me very well? Hello?
Yes, we can hear you.
Yeah, so when patients present either with ascites, hepatorenal syndrome, hepatic encephalopathy, variceal bleeding, and spontaneous bacterial peritonitis, that's called decompensated cirrhosis. The rest is compensated cirrhosis. Why is it relevant? What is the clinical significance? Patients with decompensated cirrhosis have a higher mortality. Usually they do not survive within 2 years of time. The other point I wanted to clarify, the complications of cirrhosis. For you to remember it, it can be remembered into two things. Complications that are related to portal hypertension and non-portal hypertension complications. Mashallah, they have covered the complications, most of the complications related to portal hypertension, which are ascites, varices, hepatic encephalopathy, cirrhotic cardiomyopathy, all of those things. But don't forget the non-portal hypertension complications, which is number one, altered drug metabolism. Don't forget that the liver metabolizes almost half or more than half of the drugs that patients take. So when patients have cirrhosis, you need to be mindful the type of drug you're going to give, and is it excreted in the liver or in the kidneys? So that's number one. Number two, sarcopenia. They present with hypogonadism. Then hepatocellular carcinoma and coagulopathy. Okay. Now, let's come back to our patient. One thing I want to highlight is the management, how that patient was managed, especially when they present with ascites. The first step, which I think Ayaan mentioned in our management, is the diet. Ruqiya did not mention that the patient's diet was the first step of managing ascites is salt restriction. And it's a specific gram. It's 5.2 grams salt per day, maximum. Or you will tell the patient no added salt to the diet. That's very important, because you can never call a patient, you can never say it's refractory ascites unless you make sure the patient is not taking more than 5.2 grams per salt per day. And how do you check that? You check for the urinary excretion of salt. And if it's exceeded more than the daily requirements of salt, then it means that this patient is not compliant. Now, the second part of management of ascites, especially in uncomplicated ascites, is medical therapy. It's not therapeutic paracentesis. This patient was started with tapping. The first line is you start with spironolactone, and you have to go to the maximum dosage, up to 400 milligrams. Then you add furosemide. This patient was started on only 100, and that's it. And he was discharged with 100. And then the third thing, which was I wanted to highlight, was it was done therapeutic paracentesis with a patient who already had a low albumin, an albumin of less than 20, and he was not given an albumin. So remember that number one management of ascites is a salt restriction. Number two, spironolactone, which is you have to go to the maximum dosage of 400 milligrams. And then furosemide, and you have to reach up to 160 milligrams. Now, what is the target weight loss in cirrhotic ascites? You have to have a daily weight for the patient when you admit. And the target weight loss, if the patient comes with severe edema, there is no need to slow down the rate of daily weight loss. But once the edema has resolved, the target weight loss is 0.5 kg per day. So you need to weigh your patient daily. Now, what's a refractory ascites? Refractory ascites is ascites that cannot be mobilized or early recurrence occurs, which, even after therapeutic paracentesis, cannot be prevented by medical therapy. So there are two subgroups of those refractory ascites. Diuretic resistant ascites, which the reason that I said you have to reach to the maximum dosage, because if the patient cannot tolerate the maximum dosage of spironolactone, then that's a diuretic resistant ascites. And the second one is a diuretic intractable ascites, which is ascites that's refractory to therapy due to the development of diuretic-induced complications, which are hepatorenal syndrome, one of them. And remember that refractory ascites has a very high mortality. 50% of patients die within 6 months of having the refractory ascites. Now, the second point I want to mention is there is a new diagnostic criteria for hepatorenal syndrome, which you should be aware of it. And the criteria, number one, it's a cirrhotic patient with ascites. Number two, the serum creatinine has to be more than 1.5 milligram per deciliter. Number three, there is no improvement of serum creatinine after at least 2 days with diuretic withdrawal and volume expansion with albumin. So the recommended dose of albumin is 1 gram per kg of body weight per day, up to a maximum of 100 grams per day. Number four, there is an absence of shock. And number five, there is no current or recent treatment with nephrotoxic drugs. And there is absence of parenchymal kidney disease, which can be quantified by proteinuria or microhematuria or an abnormal renal ultrasound. So you have to meet all criteria to say that the patient has to have hepatorenal syndrome. And there are two types of hepatorenal syndrome. There is a type 1 and type 2. Type 1 is defined by a rapid progressive renal failure or the doubling of the initial serum creatinine greater than 226 millimoles in less than 2 weeks. Type 2 is a less severe, which is characterized by moderate renal failure. The other point I wanted to mention was you need to be able to differentiate between spontaneous bacterial peritonitis and secondary bacterial peritonitis. Remember that spontaneous one is a monomicrobial infection of acidic fluid. The secondary one is a polymicrobial infection. And the secondary bacterial peritonitis, there is a presence of surgically treatable source of infection or a source of sepsis. A neutrophil count, usually, it's very high in the thousands in the secondary bacterial peritonitis, and it's normally the hundreds in the spontaneous one. And the sugar is very low in secondary bacterial peritonitis, and protein also is very low in spontaneous. So remember that the sugar is low in secondary, and the protein is low in the spontaneous bacterial peritonitis. I think I've covered most of the points I wanted to mention. Dr. Dekkow, you can take the floor. Thank you.
Okay, Dr. Dekkow cannot speak, so and the floor is open for any questions, either by typing through the chat box or by just unmuting yourself. Any clarifications?
Hello.
Hello.
Assalamu alaikum.
Alaikum salam.
I meant I can't speak because you weren't allowing me to say something. Oh my God.
Okay.
So I think it's not appropriate for me to say something. My senior colleague, Dr. Hadi, has mentioned most of the things. Mine is just to thank the entire team, and maybe in the interest of time, I don't know, just to capture one or two things. The definition, Ayaan, that time-based definition for chronic liver disease, I don't know where it is from. I don't think it's a consensus at the moment. Most definitions are not time-based, to be honest. I don't know if you're conflating with the hepatitis B surface antigen one, but chronic liver disease is not necessarily a time-based one. Anytime the liver's synthetic function has been destroyed in a manner now where you're manifesting with any of the complication that is mentioned by Dr. Hadi, you already have a definition of chronic liver disease, and then maybe decompensation or not, depending on now whether you've seen the chronic liver disease complications, specifically encephalopathy, ascites, the one that Dr. Hadi had mentioned, and then variceal bleed. That definition has to be clarified. In the history taken, I think, which most of the students are interested, let me just pose a question. This patient was edematous, had lower extremity edema. The creatinine levels were high. What makes you believe this is liver disease and not necessarily chronic liver disease, chronic kidney disease, sorry, with the fluid overload? That I think has to be very much in keeping with the entire message. Just go back to that history again. Also, why not heart failure? We've mentioned no edema, fine, no orthopnea. I don't know if the distended neck veins were mentioned. Were they captured? If they weren't, please, when you're examining a patient who has got lower extremity edema, yes, in the interest of this discussion, fine, we're discussing chronic liver disease, but make sure you look at those vessels. If there is any edema, if the neck veins are distended, now probably because patient could be having two diagnoses. They're not necessarily having one chronic liver disease. The Occam's razor says one disease explains everything, but also they could be having two diseases at the same time. The principle of Hickham's dictum. Mine is just to analyze those two things. And also, importantly, most of the patients that you see here, I think the liver disease problem is not necessarily going to be obvious that you are going to see alcohol, because if you see somebody who has got liver disease and it's not the typical alcoholic patient, what are you going to think of? In the history taken, please ask about transfusion. The majority of our people, Somali people who have got liver disease, is not necessarily from alcohol. There is unscreened hepatitis B. It's floating in the problems. It's just people don't screen transfusion from where they come from. There's actually vertical transmission right from childhood, and then you end up with all problems. And then of importance, before I forget, hepatitis B is notorious for not giving you for not going through the chronic liver disease, cirrhosis, then HCC. It just goes from hepatitis B straight to HCC. The next morning you have AFPs in thousands, and then you have a big mass, and you have hepatocellular carcinoma. I think those are the things probably I wanted to mention, but the rest of the management and everything else has been excellent. Thank you very much for having us. I think in the interest of time, unless there's anything else, I am leaving the floor to the team leaders.
And
thank you very much.
Doctor, there's a question here. And kindly, what were the conditions that will be considered for decompensation?
Shall I take the floor, Dr. Hadi, or will you just go through that question?
Look, I've already mentioned that.
Good.
But to repeat, decompensation, it's only 5 conditions. If patients present with variceal bleed, ascites, hepatorenal syndrome, hepatic encephalopathy, and the 5th one is spontaneous bacterial peritonitis. Before I forget, Ayaan mentioned that in our setup, alcohol is the most common cause of chronic liver disease. I don't think that statement is correct, Ayaan. And I want to make it very clear. In sub-Saharan Africa, is still the most common cause of chronic liver disease is viral hepatitis. Don't forget that. Alcohol is second. It's not the most common.
Or maybe the person asking meant the things that are tipping people over. He meant maybe the way you've answered. I don't know. It's not clear. What are the conditions that would be considered for the compensation? Maybe exactly. I think the one Dr. Hadi mentioned is what he wanted. Probably what is by definition the compensation. All right. If there's no any other question, I think.
Dr. Dekkow, I have one more question.
Okay.
For a patient who presents with gross like massive ascites, what's the maximum amount that you can drain in a day, and what's the ratio of now the albumin that's supposed to be replaced in that said patient?
All right, I have a lot of controversies, but Dr. Hadi should give us his practice. Dr. Hadi, I think students are specific about management. You have a patient who has massive ascites. Are you going to tap the patient dry? Will you just remove 5 liters? Please carry on.
Okay. I've seen a lot of physicians who are afraid to remove water from the abdomen. You can remove as many as the patient can tolerate. There is no specific number. Just remember that more than 5 liters, you need to add albumin, at least 8 grams of albumin per extra liter you remove after 5 liters. That's the most important thing. So if you remove 20 liters and the patient is still okay, there is no point. It's okay, it's fine. Before, back in the day, when we were in medical school, they used to say that there is a specific liters you can remove in a day, but it's no longer the issue.
All right, thank you. That is exactly what my sentiment from my seniors are. We were a bit hesitant a little bit a while ago. We just wanted to remove 5, 6. Nowadays, as long as you have albumin and you can give albumin for every liter above 5 liter, and you're in a setup whereby if the patient gets into hypertension, probably you could be in a position to monitor, tap the patient dry, and don't quote me or Dr. Hadi. All right, any other question?
Okay, doctors, there's another question in the chat box. And why is CA125 elevated in ascites due to liver disease? Isn't it a cancer marker?
Good question. Dr. Hadi.
I think Ayaan have answered this question. She can answer them again.
All right, Ayaan.
Where's Ayaan?
Yes, doc. Mostly,
Why is the patient
Mustafa,
having CA125? That's too high.
Why is CA125 elevated in ascites due to liver disease? Isn't it a cancer marker?
I actually did not mention that. Maybe the doctors, let me throw the question back to you guys.
Okay. Dr. Hadi, is there anything we're missing?
Usually patients with ascites, it's a cancer marker, but remember that you're treating the patient, you're not treating. So there is a lot of controversy actually ordering these cancer markers. And I don't know why this patient was ordered. That's number one. But it has been proven that patients with ascites, they have elevated CA125, and it's not associated with ovarian malignancy. So
okay.
It's usually associated with decompensation of the ascites. And the mechanism is not well understood.
All right, thank you. I was not familiar with that relationship. I knew of AFP and ultrasound for surveillance of HCC, but 125, CA125 in ascites and liver disease or liver problems, I am not familiar with that one. So probably it's something, maybe an area that we can all go back and probably read and consult and ask our seniors. I think in the interest of time, it's almost prayer time where I am.
Okay. And there's one last question, and it says, please repeat the non-portal hypertension complications. Last one.
All right, Dr. Hadi, please.
So, hepatic osteodystrophy, which is osteopenia, osteoporosis, that's number one. Number two is coagulopathy, which is decreased synthesis of the clotting factors and thrombocytopenia, malnutrition, sarcopenia, and then hepatocellular carcinoma. Those are the most common ones. And then, as I mentioned, altered drug metabolism and hypogonadism.
Okay. And I think we've come to the end of a truly enriching session, alhamdulillah. And a heartfelt thank you to our facilitators, Dr. Hadi, for sharing specialized knowledge as a consultant gastroenterologist, and Dr. Dekkow also, and also for his continuous support and mentorship as a senior registrar. And also to our presenters, Ayaan and Ruqiya, well done, and thank you for the clarity and the preparation for our topic today. And finally, to everyone who took the time to attend and participate, and our heartfelt thanks to you. And we look forward to seeing you in our next grand round, inshallah. And with that, subhanak Allahumma wa bihamdik, ashhadu an la ilaha illa anta, astaghfiruka wa atubu ilayk. Wa billahi tawfiq, wa assalamu alaikum wa rahmatullahi wa barakatuh.